The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Hi to everybody out there, and welcome to TMD Demystified. I am Tony Urbanek. I appreciate you following along on this episode. And today, my chosen topic is entitled TMD and the Orthodontist. I was just having a conversation with my associate, Dr. Urbina, in the practice here, and he reminded me that I have opened a Pandora's box when it comes to discussing issues regarding TMD, all issues. Well, and I'll just digress a little bit because I'm going to talk about TMD and the orthodontist. My last episode was TMD and the oral and maxillofacial surgeon. And as it works out, these series that I've invented, TMD and, open up a whole plethora of ideas and concepts that I need to cover. He reminded me that I need to do an episode on TMD and sleep dentistry, which is very important, which kind of coincides with what's going on with TMD and orthodontists. But my point is that when I first started these episodes, and I think we're up to I think this is episode number 68 in the past year and a quarter. I never thought that I would have all the topics come up that I've originated and spend time talking about the different aspects as associated with TMD that I have. And it seems that the more I do, the more topics become I make myself aware of more topics that need to be covered. So with that being said and understood that it looks like these episodes are going to go on forever, hopefully not forever, but I'm not running out of topics that are really relevant. Excuse me. So let's just get into it. TMD and the orthodontist. And the reason that I bring this up is because in our series of treating over 4,000 people here now in Middle Tennessee in our practice using the non-surgical device that we use called the Urbanek device. In that series, I and my associate have run into hundreds and hundreds, I don't know how many hundreds, maybe 1,000 out of 4,000, of our patients who have simultaneously or priorly been treated or underway with treatment with orthodontics, and many of them have been told that orthodontics is the solution to TMD. So let's start there. We see many, many patients who come into us with TMD symptoms, and they are verified through the history, appropriate history, check off, physical examination, and objective tests, including x-rays and physical examination, that they have TMD. And they have been told by an orthodontist that orthodontics is going to fix those symptoms. Now, that is a fact. Now, is it true? Is it a fact that orthodontics is going to correct headaches, earaches, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper shoulder and upper back pain, arm, hand, finger tingling and numbness, and various kinds of locking? In my observation, in my associate's observation, and doing this for 11 years and 4,000 plus cases, generally the answer is no. Would I be so bold as to say that treating a patient with a specific orthodontic treatment plan diminishes their some of those symptoms in some cases or an occasional case? I couldn't deny that. I wouldn't even want to try to deny that. But let's take it through the logic of what everyone who treats TMD needs to know. If you start out with the basic knowledge that is correct and then can apply your technology to that problem, then you may be able to solve it. But if you, and this is an old adage, but if all you have is a hammer, everything looks like a nail, and that is inappropriate. So we know the facts are that all of the symptoms that I just reeled off are directly caused by inflammation within the temporomandibular joint. So if you are an orthodontist and you tell the patient, yeah, I can fix your headaches and your earaches or whatever, first of all, you need to know what you're trying to fix. If you're going to just straighten teeth, does straightening teeth decrease inflammation within the temporomandibular joint? This goes back to previous episodes, same with Botox, paralyzing the facial muscles. Does that decrease the inflammation within the temporomandibular joint? No, it doesn't. So is Botox an appropriate treatment for temporomandibular joint disorder? The answer is no. Is Botox an appropriate treatment for the lines on your face? Yes, if you want to use it for that. Is orthodontics an appropriate treatment for temporomandibular joint disorder and decreasing those symptoms? Well, the answer to that is only if you are certain that your orthodontic treatment is going to decrease the inflammation within the temporomandibular joint. Now, I don't know why this concept and this series of logical expectations to the solution are not taught in orthodontic training programs consistently. If you are going to treat the mandible and the teeth in it, you need to know these facts. And it appears to me, based on both younger and older and middle-aged orthodontics that are in our neighborhood, which is all of Middle Tennessee, they are not aware of this, and they continue to do things orthodontically that have unintended consequences, or that they recommend orthodontics for the treatment of temporomandibular joint problems that are not going to solve the problem. And so there are two concepts that I want to cover here. Number one, the orthodontist who claims that orthodontic treatment is going to treat TMD. And secondly, the orthodontist who does various types of traction on the mandible. I have no issue with the traction on the teeth, but if you're putting traction on the mandible, you are putting traction of one type or another on the temporomandibular joint. And traction on the temporomandibular joint by design and fact will cause chronic inflammation, just like bruxism, clenching and grinding, will cause chronic inflammation within the temporomandibular joint. We know that. Chronic traction on the temporomandibular joint will cause chronic inflammation, and chronic inflammation is the description and the definition of TMD, along with the symptoms. The symptoms are the descriptors, but actually TMD is nothing more than one level or another of chronic inflammation within the temporomandibular joint. That chronic inflammation can go on for 2 months, or it can go on for 50 years, but it's chronic inflammation that causes the damage. It's chronic inflammation that causes the symptoms. And then, of course, there's acute trauma, which causes inflammation. So getting back to orthodontics, and again, this is from my own personal observation after 11 years now treating TMD non-surgically. I see many orthodontic patients who have been told that orthodontics will treat their temporomandibular joint disorder, and they go through a series of 18 months, 2 months of orthodontics. Their occlusion may be improved significantly, but they still have TMD symptoms. I think there are many circumstances how that happens. I think the orthodontist doesn't consider bruxism, or somehow thinks that getting the teeth aligned correctly and taking out whatever discrepancies in the bite is going to keep them from bruxing. I know that patients have been told that if you get their teeth straight, they'll quit bruxing their teeth. That is not true. That is just not accurate. It's not true. We do not understand the mechanism of bruxing. There are theories about it. There are things in the textbook, but if you read the textbook critically, or you read the paper critically, if the paper is at least halfway honest, they're going to say, well, we consider, or we think, or this is a theory as to why bruxism is happening within the central nervous system. The only thing we know about bruxism is related to stress. The more stress, the more people brux. Half the population bruxes their teeth. Most of them are not aware they do it, but it's a very common phenomenon that we doctors in the sciences, dentists, medicine, neurologists, do not fully understand. We know that there are mechanisms within the brainstem that are associated with this, and beyond that, it is all theory. And there is no on and off switch for bruxism. There is none. Patients have no control over it. But there are orthodontists who claim, or tell patients at least, that if they straighten their teeth, it's going to stop their bruxism. And via that, it's going to correct their temporomandibular joint disorder. Well, that's not accurate. That's not fair. And the way we know that is we have a list of patients who come to see us who have gone through orthodontics, or many currently in orthodontics, and their temporomandibular joint symptoms persist. And then when you unload the joint long enough in a proper way, by unloading the joint, the inflammation diminishes and the symptoms ameliorate and go down and go away significantly. Between, we talk about that. How do you measure that? Well, that's a different episode. That's a different topic, but we measure it, and the satisfaction rate and the measurements are very, 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 very high. So the message to my orthodontic colleagues and anyone else who's listening, and my general dental colleagues who do orthodontics, and more frequently than not, orthodontists, general dentists are delving more and more into orthodontics, especially now with aligners. So that brings up that topic. Okay, aligners are doing orthodontics. Now, if you are just aligning a tooth or two or spaces with an aligner, and you're not putting traction on the mandible, no problem with that. If you're not putting traction on the mandible, what I'm saying has no application. But there are instances where aligners are putting traction on the mandible, which will cause chronic inflammation within the joint. And once that gets going, will cause TMD symptoms. So orthodontists, whether you be general dentist or a specialist orthodontist, needs to be aware of this and to factor that in to your recommendations and your treatment plan, and knowledge that you do not want to do something that has unintended consequences. The orthodontist, similar to the surgeon, does his trade, does his service, and then sends the patient out the door. And more often than not, once you go through the immediate postoperative time, doesn't see the patient again unless there is a problem. And most of the times they don't get to see the problems, especially in this case, the problems generated by orthodontics. Orthodontist sends a patient back to the general dentist, and if the patient continues to complain of the symptoms of TMD, well, the orthodontist is never going to be aware of the unintended consequences of his orthodontic treatment. So in that category, I would definitely bring to everyone's attention that to recommend or tell patients that orthodontics is going to correct your temporomandibular joint disorder is not accurate unless you can say and are certain that your orthodontics is going to decrease the inflammation within the temporomandibular joint. And if you can say that honestly and believe that, and hopefully can show that statistically with your treatment, then I'm all for it. If you can do that, I don't think that can be done. That is my opinion, and I stick by it. So I hope, it sounds critical. I guess it is critical. I don't mean to criticize. What I do mean to do is bring these facts to the attention of my profession. And I am just sometimes as critical of my oral and maxillofacial surgery colleagues as I am sounding of my orthodontic colleagues, because of the lack of understanding of temporomandibular joint problems in those two categories and many other categories. Certainly, if the doctors don't understand it, the patients don't understand it, because their information is all filtered through the doctor. So this is one good example. I have to confront this problem with my colleagues, and if I'm disliked for it or, whatever, it's okay with me. I ask anyone listening, and I ask my colleagues to prove me wrong. I ask sincerely, prove me wrong. And if you want to make comments or criticisms, as I've said in many, many episodes, please do. Because there's nothing wrong with academic debate. And there are facts, which brings out interesting. I like to quote different individuals in my presentations. I always use different quotes from different people. I ran across this one. I'm just going to quote it just out of the blue, but hopefully you can relate to it. Actually, this quote is attributed to two people. I'm not sure who actually quoted this first, but Mark Twain or Benjamin Disraeli said, "There are lies, there are damn lies, and there are statistics." And that is actually true. And although statistics are how our current scientific group manages and validates different studies, so I'm not saying statistics are not valid, but you can kind of prove anything with statistics if you are skilled, highly skilled in using statistics. But that isn't to delimit the use of statistics itself. I just had that on my desk here. I thought I'd throw that. I'll probably use that again in my presentations, and both in public and on the episodes in the podcast. All right, so the orthodontist has a responsibility to speak accurately, to have the knowledge, and it is just not appropriate, in my opinion, for an orthodontist to say, I can straighten your teeth and it's going to make your TMD symptoms go away, whatever those symptoms have to be, whether they're one of them or all of them, unless he's absolutely certain that his treatment is going to decrease inflammation within the temporomandibular joint. So there are many adverse effects by doing orthodontics. The second category that I want to talk to regarding the orthodontists is the traction that they use on the mandible. In many, many cases, starting very, very early. I just saw a case yesterday. A young 10-year-old had been in orthodontic treatment for 2 years, meaning she started her orthodontic treatment at age 8. Again, I'm not current with the philosophy of orthodontists, and I know it changes from school to school and year to year sometimes, or decade to decade, but is it really necessary to start orthodontics on an 8-year-old? In any case, she was in my office with her mom and dad complaining significant TMD symptoms, and actually had significant TMD symptoms with a hot joint. Joint was painful and had headaches and jaw pain, ear pain. Now, whether her symptoms were caused by the traction that was currently she was undergoing on her mandible, I can't say for sure, but she was undergoing traction. She had a class 2 position. She was undergoing traction. Now, traction can be placed on the mandible, talking traction on the mandible, not teeth. If you want to, put traction on a first molar to straighten a premolar, that's different. But if you're putting traction on the mandible, either a class 2 traction to bring the mandible forward or a class 3 traction to bring the mandible back, I can promise you over a short period of time at any age, because it's going to create chronic inflammation in the joint, temporomandibular joint. My training, if I'm trained in anything else, it's in growth and development, and I've applied that to my maxillofacial profession and my skill set for 46 years. Facial growth and development, how the face grows. And one of the primary, if not the primary, growth center of the entire face is the temporomandibular joint. Now, there are other growth centers involved, but if you align them in degree of where the growth comes from and the degree of growth responsible from that particular area of the face, the TMJ is head and shoulders above everything else. So if you have unintended consequences, if you have damage, if you create damage to the temporomandibular joint, especially in the early growth and development, you can damage the joint to the point where later in life, they are going to develop, if they don't develop it at the time of traction, they are going to develop TMD symptoms as they grow older because of the damage done by unintended consequences of traction to the temporomandibular joint. So there can be, different kinds of traction. You can have intraoral traction, like a Herbst appliance, which is removable but puts traction on the mandible to bring it forward. And there's, if you can imagine, if you had chronic traction on your knee joint, pulling your leg down, constantly for months and months and months, the effect that would have on the knee joint. Well, this joint is no different than any other joint in the body from the standpoint of it works just like a joint, and the pathophysiology and the neurology of how this joint works and the knee joint works is similar. The anatomy is different. Of course, it's smaller. It has its certain specific delineations of how it works, different than a knee or an elbow or a hip, but it works like a joint. And if you put too much pressure on a joint, it's going to break down. If you put too much traction opening the joint long enough, it's going to damage the joint. If you put too much traction compressing the joint, it's going to break down. That meniscus, which has a very poor blood supply, will be the center of where the inflammation is created. And then over a long period of time, it will spill over into the other anatomical features within the joint. And as we know, the disc gets loose and it gets displaced, and it has all kind of descriptors as to why it does that. But the point is, it makes no difference where the disc is and how much damage is in the joint. It's all about the amount of inflammation in the joint and that inflammation causing the symptoms. So orthodontists should be very, very cautious, extremely cautious about putting traction on the mandible. As an oral maxillofacial surgeon, I fought this battle throughout my entire career, where the orthodontist maybe at the behest of the patient. I don't want surgery. Patient mom says, or the patient themselves, I don't want surgery. What can you do for me orthodontically without surgery? I understand the problem. I understand the issues. I've dealt with it. I dealt with it for 46 years. But the proper way, if you have a functional malocclusion, which includes a disproportionate maxillofacial facial structure, including position of the mandible, the proper thing to do is to use your orthodontic skills and proper oral and maxillofacial skills to surgically put the facial skeleton, i.e., in the most common one is mandible, in the proper position, and then adjust the occlusion with orthodontics. It's self-evident. It's simple. The fact that people don't want or don't like surgery, I understand that. I hardly ever did any surgery on anybody at any time that said, oh, I can't wait for surgery. That doesn't happen. But do we want to handle a problem correctly or incorrectly? Do you want to do what's best for the patient? If you, at least you need to tell, this was my issue with orthodontists, at least be honest and tell the patient the right way to do this. This is the right way to do it. Now, if you want to do it kind of in a Jake leg way and to attempt to correct a facial skeletal growth problem using traction and intraoral braces, and that's what you want to do, and you understand that that's not the best way, then who would argue with you? The patient is in control. No problem for me. But the patient needs to know, again, it's all filtered through the doctor. The patient needs to know the best way to do it, and then let them decide what is the best way. And that's what the orthodontists, except in some cases, but in most cases usually don't do. They don't tell the patient the best way to do this. The most accurate way to do this is to use orthodontics and surgical techniques to correct your facial, orthognathic, jaw, and facial growth bone problem. Getting back to how that needs to be handled with or without traction, I would highly not recommend, external head frames, which were very common when I first started my career, which I don't think are as common anymore, thank God, but I think they are still used. But any kind of traction, intraoral traction, extraoral traction, putting traction on the temporomandibular joint does damage the temporomandibular joint, and you are taking, for the patient's sake, you're taking chances that is going to create long-term TMD problems, because we see that here all the time. We just see it all the time, and we have the statistics to show it. I mean, and we're keeping track of it. And remember what I said about statistics, you got to be careful about statistics. So we talked about how the orthodontist does not actually get to see most of the time the consequences, unintended consequences. I don't think as an orthodontist that would intentionally want to hurt people, but I think that because of lack of knowledge and understanding about what TMD is all about and where the symptoms come from, there is significant amount of misunderstanding from my colleagues, both general dental colleagues, specialists, oral orthodontists, and certainly oral and maxillofacial surgeons included in that group. And that is my intent, and that is why I do this podcast, and that is why I specifically kind of zeroed in on the orthodontist today. So I challenge my orthodontic colleagues to look at this critically, look at what is right for the patient, not necessarily what is right for the practice, and to consider those two concepts as they do use their daily skills. And number one, to delete from telling patients that orthodontics is going to treat their inflammation within the temporomandibular joint unless they are absolutely certain that that is actually what they're doing. And then secondly, to be extremely cautious about putting various kinds of traction, extraoral head frames or intraoral devices putting traction on the mandible, which will create damage within the temporomandibular joint, chronic inflammation, and therefore TMD symptoms. That is as concise as I can make it, even though I may not have been fully concise. That is what I wanted to get across today. As always, as I've said, I appreciate comments. I appreciate criticisms regarding what I have to say about the cause of temporomandibular joint symptoms in general. I ask that anyone out there with anywhere near the experience that I have, or has the statistical evidence, or wants to have studies of their own that disprove what I am saying, please bring it to my attention. I'll be more than pleased to look it over and have a discussion with you regarding this. Because what we really want is we want a solution to TMD. We want the best and easiest way to solve the problem of TMD, which is almost pandemic. I hate to use that word. Let's not use that word. Let's just say extremely common. 45% of females have temporomandibular joint symptoms. It has many males also, but it is just a huge problem. And in many cases, just ruins lives. And we need to get this handled. The only way we're going to handle it is about disseminating the information to as many providers as possible to finally get to that critical mass, just like the critical mass of aligners got to the critical mass. Now everybody has jumped on board and understands at least the basics of what an aligner does and how it can affect their patients and how it can affect their practice. That's fine. And that's a debatable option too, but I don't want to go there. I won't go there. But regarding TMD, this is just a huge problem. We've talked about TMD and Meniere's disease, ringing fullness dizziness. It's just coming to light. It has just come to light with my work that Meniere's disease does not have a solution with the ENT doctors, but Meniere's disease, those three symptoms, there is a solution when those three symptoms are caused by inflammation within the temporomandibular joint. And we're working on that aspect of it aggressively right now in bringing it to the attention of the ENT profession establishment. I appreciate your attention today. I look forward to speaking with you at the next episode. I'm not running out of topics. It seems my topic list is growing rather than decreasing. Hopefully that's a good thing for you. It is a good thing for me because my intention is to really bring the solution to TMD to the general public and to demystify the concept and the disease called temporomandibular joint disorder. I am Tony Urbanek, and for today, I look forward to speaking with you again.